Welcome to This Week in Health IT Influence, where we discuss the influence of technology on health with the people who are making it happen. My name is Bill Russell, recovering healthcare CIO and creator of This Week in Health IT, a set of podcasts and videos dedicated to developing the next generation of health IT leaders. This podcast is sponsored by Health Lyrics. Professional athletes have coaches for every aspect of their life to improve performance. Yet many CIOs and health executives choose to go it alone. Technology has taken center stage for healthcare. Get a coach in your corner. Visit healthlyrics.com to schedule your free consultation. 2 new services on the website want to make you aware of. This Week Health Insights is for individuals looking to propel your health IT career forward. 2 emails a week designed to give you insights that set you apart. This Week Health Staff Meeting is for teams, really for managers looking to introduce your teams to new thinking from industry leaders to get the conversation started on the right foot. If either of those 2 are of interest to you, hit the website and hit subscribe. If you're going to be at the health conference in Vegas at the end of October, you're going to want to stop by a discussion that I'm going to be moderating on Tuesday, October 29th at 12:40 with VMware, Deloitte, Intel, and others. It's going to be a discussion on the opportunities, challenges, and promise of leveraging multi-cloud environments for healthcare. If you're there, please stop by. I'd love to see you. We caught up with Dr. Don Rucker, the National Coordinator for Health Information Technology for ONC, at the Health 2.0 conference. And we discussed what it's going to take to get data in the hands of the patients. Have a listen. Hope you enjoy. Another session from Health 2.0. I'm with Don Rucker, Dr. Don Rucker, National Coordinator for Health IT for HHS. Welcome. Thank you.
Thank you, Bill. Yeah.
So you're a physician technologist. Give us a little of your background.
Okay. Well, I started as a doc. I was actually in medical school when I realized American healthcare is sort of a odd, bit of a highly ineffective activity. In many ways, just sitting as a first-year medical student, seeing the goings-on. So then I got interested in some things like decision analysis, and realized ultimately one of the things that was needed was actually more data, and the only way to really do that was with computers. And so I did a very unusual career move, which is to go from residency to grad school in computer science and learn computing, and then have been involved in healthcare IT ever since.
Wow. So what was the state 30, 40 years ago? I mean, you probably couldn't do basic stuff.
Well, the state was paper charts.
Right.
I mean, simply, if you were, I've spent most of my career as an ER doc. There were just paper charts on a clipboard. If you were in the hospital, you had a binder from the hospitalization or a clipboard. Labs were pasted with like little sticky third of a page pieces of paper into the lab section of a paper chart, shingled like shingles on the side of a house. You could actually tell a fair amount about a patient's illness because each lab type had a different color code on the edge of the paper. So you could look at a paper chart sideways and have a pretty good idea, given the number of tests available, what the patient's problem was from literally looking at the chart sideways.
Wow. So in some ways we've come a long way.
Yeah.
In some ways we haven't. And there's an awful lot of things coming out of your side of the government around data sharing.
Right.
So let's just start with the basic question. Why is data sharing so important?
The real key about data sharing, I mean, there are a lot of things about operational efficiency. The real key is, can we put the medical record, the medical chart, and the medical care in the patient's hands, right? And that was sort of a rhetorical question at best. 10, 15 years ago, we had no browsers or no effector browsers. We certainly didn't have smartphones. Now, we actually, for the first time ever in the history of civilization, not that they probably had a lot of medical records 100 years ago, but now for the first time, we have a technology both to generate the electronic record and to get it to the patient. So the real power of these, what are called APIs, application programming interfaces, is to get the data to the patients so the patients can chop on it, control it, reflect on it, especially in a world where we know much of healthcare is about what is sometimes called social determinants of health, but ultimately, in many ways, are lifestyle choices that we make about what we eat, what we exercise, how we take care of ourselves. So to have the patient become an active participant in healthcare rather than a passive, go to the doctor's office kind of thing is really at the heart of interoperability.
So we had Dr. Rod Hochman on the show, and
Sure.
I asked him the question of, who owns the medical record, and he clearly said the patient owns the medical record. Now, is that universally accepted, or are you still finding some pushback on the patient owns the medical record?
Well, I'm going to paraphrase what my lawyers tell me here. That's always sort of an irritating thing for an interviewee. But I think with the exception of Vermont, I believe, where I think the patient legally owns the medical record, legally the provider who generated owns it. What we're really talking about is who has access to it and control of it and a guaranteed right of access. Under HIPAA, under the Health Insurance Portability Affordability Act, that right of access, which hasn't really been much of an issue because historically the right of access has just been go to medical records, but now electronically with the Office of Civil Rights and ONC in the Department of HHS with a lot of help from the White House, we are making it so that patients have operational access to their records. That's what's really needed here, because the ownership issue is on the patient's ability to choose their provider, figure out what the value, the economic value of their care is. That's where the ownership resides, and that's what we're really bringing in. I think that's the modern way of thinking about it.
It's interesting. I never made that much of a distinction between ownership and access. 21st Century Cures Act really represents the fact that this idea of freeing the data for the good of the community, for the good of the patient, for better outcomes, is really a bipartisan effort. It's at HIMSS this year we saw 4 administrations represented, all saying essentially the same thing, which is we have to enable the innovation community. We have to talk a little bit about the 21st Century Cures Act. And because I think people feel like this administration is coming down with all these things, but it's not really the case.
Yeah, that's a great point to make. There's been a lot of, certainly Office of the National Coordinator, there's been a lot of bipartisan continuity for absolute sure. So what has been noticed under President Obama and the coordinators, so we're talking David Blumenthal, Farzad Mostashari, Karen DeSalvo, and Vindell Washington, to be clear, is and what Congress had noticed, more importantly, since it's a law, is that a lot of times there was information blocking. Now, I want to make clear one thing you said. We think there will be benefits to the broader community, but a lot of this is specifically the patient's right to access. So that's where the legal calling is. And a lot of that came from not having application programming interfaces or having them and not opening them up. So what Congress said is, look, this information is in many ways a public good, right? Paid for either directly by the American taxpayer or indirectly through the way we apportion income tax. And so this public good should not be sequestered away by private parties. It is really a public good. That was, as you point out, almost unanimous in the House and the Senate. It was December 2016. As folks remember, there had been an election just before that, and probably everyone was surprised at the outcome, arguably. And so this was a law signed by President Obama. I can absolutely assure folks that President Trump, the White House, Secretary Azar, Administrator Verma are very much, obviously ONC, are very much in sync with giving patients this right and making that highly operational. and it is absolutely bipartisan. We got, in the public comment period, we had a letter strongly endorsing the approach in our rulemaking to that law by all 6 of the prior national coordinators. Oh, wow. So Dave Brailer, Rob Kolodner, and the 4 coordinators, and we've worked together on a number of things. So absolutely bipartisan, strong bipartisan support, and a shared vision of all of the 6 prior coordinators as well in getting this in front of patients.
So some of the opposition will come around privacy and it'll come around complexity. So from a complexity standpoint, we heard at a recent user group meeting, we heard essentially that this is way too much work. They're going to set the EHR community way back because all we're going to be working on is building these APIs, and we're not going to be doing any innovation for the next, I think it was 5 years or 3 or 5 years, whatever it was.
Yeah.
I mean, what do you, I mean, you've been doing this for a number of years.
Yeah. Well, without getting into specific user group meeting events, the comment was made that you would need an individual API for every combination of data shared. That, of course, is computer science nonsense. To be sure, we have passed variables into functions since the dawn of time. It is an extremely basic computer science concept, and that vendor, as well as I think all of the other major vendors, already have FHIR APIs existing today. Now, that's not to say that this, what we're proposing in the rule is straightforward, is having the EMR database have a sort of FHIR endpoint, so a FHIR version to initially start around the US core data for interoperability, things like medication list, problem list, allergies, notes. And so that is a server with an address on the internet that then the patient authenticates to in the exact same way with the exact same methods that they do to provider portals today, but with their smartphone app. So this is very patient empowering. We think it is a very straightforward thing to do. The vendors, many of them have already done it, have it up and running. So, for example, to the point that was made on, that it would take to the umpteen zillion APIs, I think was the statement made on one user group meeting, the vendors have already done this with Apple and HealthKit, right? So if you look at Apple's HealthKit, there are literally thousands of endpoints that from hundreds of separate organizations that people can access today. So those are FHIR endpoints. So there's already a proof statement that this exists.
Right, and there's also third parties that have developed these APIs.
Yeah, so now, I think to your point, this is potentially a transformative event for healthcare in terms of whether, who has the power, who has the control, and there's people who don't want the world to change.
So the last two things. I have to touch on privacy because
Sure.
One of the other arguments is that the framework for securing that data is not clear yet. So some nefarious actor could write an app and give it to my parents, who would just,
Right.
and we could have another.
Yeah. So I think there's two things to think about here. One is security and one is privacy. So in security, we're doing the OAuth 2 authentication. That's a straightforward thing. It's used in the military, banking industry, brokerage industry. So we have a lot of data points that this is a very secure approach, and obviously this will evolve over time. Any access to the patient's data is generated by the patient specifically themselves. A number of folks have said, though they know that not to be the case, that just anybody can somehow just randomly get the data. That is not true. The patient is the one who has to authenticate. what's been raised, I think, is a valid issue to think about. And of course, we're not thinking about just in healthcare, we're thinking about it with everything in data, are secondary uses of data, right? So this is the issue with the European GDPR, this is the issue with the California Consumer Privacy Act, and this goes to 4 apps that patients have chosen, and of course, probably the most widely used businesses that exist purely because they're selling data are, of course, Google and Facebook, right? That is, as one of my colleagues puts it, you're the product with those companies.
Yeah, if you can't figure out the monetary, how they're monetized.
Right, so, in healthcare, I think there are going to be a variety of different business models, and that's what we want to encourage. We want to get competition in there and to give people a choice and lower prices. Right now, the law is that if you mislead people on what you're doing with that data, you're subject to the Federal Trade Commission Deceptive Business Practices Act. So that was, for example, the $5 billion fine to Facebook. Congress is, and we're looking at what things we can do with our current authorities in terms of this OAuth 2 authentication process to hold apps accountable for certain business behavior as part of the authentication protocol. There's a lot of interest, obviously, in Congress on, reuse of data, secondary use of data. A lot of bills currently, floating through for consideration. Something that I think is very important here, though, that is part of that new technical world we live in, is we've historically thought of data, health data, as just that HIPAA data, right? The medical record, whether it be paper or electronic. In this modern world, the vast bulk of your health data, and there are even sessions at Health 2.0 that are going to talk about this, is my understanding. The vast amount of data that can allow inferences around health has nothing to do with the medical record or HIPAA or ONC or the Cures Act, for that matter, in any way, shape. So if somebody accesses your GPS data and you're at the STD clinic or the HIV clinic or the methadone clinic every week, they have a pretty good idea of what your medical problem is, right? If somebody says, hey, your main trip every day is to the liquor store or the bar or McDonald's, there's vast amounts of highly actionable data that's inferred. If they download, as they can, your accelerometer data, say, hey, Bill or Don, they don't seem to be doing any exercise, right? They're just sitting there moving a tiny bit. And, whether this is credit card data, search data, all of that gives vast amounts of health information. So I think part of our encouragement for people to think about is to think about health data in its totality as we think about what to do next here. All of that having been said, what we're really talking about is, does the patient have a right to get their data, right? All the people who want to protect the patient, pretty much all of whom seem to have huge economic interests in having no transparency on their business models, it should be the patient's choice. If you don't want to put your data at risk, you don't have to download an app, and you're exactly the way you are today. But it's the patient who should choose that, not some paternalistic, self-interested, provider organization.
Right. And we could close there, except I want to do a Simon Sinek on you. So we begin with why, and the why. So what does healthcare look like once let's assume 21st century cures, we're publishing, prices people can see, and will we create a market where the market actually works in healthcare?
Will we, or
Is it possible? Is it possible to build a market where people can look and say, "Hey, this provider's good. I'm going to get better outcomes. There's a better cost. I'm not."
Yeah, I think
Is that a goal?
Yes, it is absolutely unequivocally a goal. It's the central goal, in fact, is to put the consumer back in charge. Consumers are in charge when there's a free market.
Yeah.
Nobody tells you what kind of car to buy, right? There's a free market, and you pick what car you want. You want a junker beat up? We're here in Silicon Valley. People seem to have a lot of money and drive fancy cars. Whatever. What we're trying to do here is, by having information, empower consumers to do that. Now, clearly, we're in a funny kind of world where we have a lot of third parties buying our healthcare, whether it's the federal government through Medicare or Medicaid, whether it's employers. And so that if a third party is buying it, it's sort of taken away from us. It's worth noting, however, that increasingly, because of the costs, more and more of these costs are actually being shifted to the public. So roughly half the spend for people who are covered by private payers is borne by the patients directly, not via the insurer. Of course, economically, they bear the entire cost because that's coming out of their paycheck. In that world, there's going to be a lot more shopping. We're already starting to see that, and at a whole bunch of edge cases, and it is going to happen more and more and more. Frankly, in some of the Medicare world, there's starting to be cost shifting, co-pays, and Medicare beneficiaries have a number of out-of-pocket costs that ultimately they're responsible for. So I think the combination of modern information technology and folks who are at economic risk is going to power that, even if we don't really make any fundamental legislative changes.
Well,
and of course, the president is huge on price transparency, so you're going to be seeing rulemaking to make that easier for the American public.
Well, as a patient and a technologist, I hope you're successful.
Thank you very much, Bill. A
time.
Pleasure talking with you. Thanks.
ONC and HHS wants to engage and empower patients, and they believe that by putting data in their hands, that we are going to get a whole new set of engaged and empowered, not only patients, but consumers. Please come back every Friday for more great interviews with influencers, and don't forget, every Tuesday we take a look at the news, which is impacting health IT. Keep your feedback coming, Bill, at thisweekinhealthit.com. It's all really helpful, good, bad, or indifferent. It helps us to make a better show for you. This show is a production of This Week in Health IT. For more great content, you can check out our website at thisweekhealth.com or the YouTube channel thisweekhealth.com, and go to the top right, click on YouTube is the quickest way to get there. Thanks for listening. That's all for now.